Bismillah ar-Rahman ar-Rahim. Our lecture for today is the maternal physiology of pregnancy. The reference of this lecture is the textbook of obstetrics 10 teachers, and there's a nicely written chapter describing this wide subject. Objectives of this lecture is to describe the main physiological changes that occur in normal pregnancy. This will affect all the organs and systems in the body, and how these changes will influence maternal nutritional requirement. Is there any need to adjust maternal nutrition during pregnancy? And also we will describe how carbohydrate metabolism is affected in normal pregnancy. As we said before, the physiological changes will affect all organs in the body, including cardiovascular, urinary, respiratory, GIT, immune system, carbohydrate metabolism, and also the thyroid gland. Regarding cardiovascular system, the changes will affect blood volume, cardiac output, stroke volume, heart rate. All of these are increased in normal pregnancy. And you know that the cardiac output is the product of heart rate multiplied by the stroke volume. Regarding blood pressure, as you know, hypotension is a physiological symptom in the pregnancy. That's to say, there will be decrement in the blood pressure, especially in the first and second trimester, and this will be returned to normal pre-pregnancy level at the third trimester. Also, the effect of a gravid uterus on the aortocable compression. There is supine hypotension due to the effect of a gravid uterus, pressure of a gravid uterus on the aorta and inferior vena cava in supine position. This will cause hypotension. That's to say, blood pressure should be measured in sitting position or left lateral position in pregnancy. The cardiac output, stroke volume increase from the first trimester. The cardiac output increases by 40%, stroke volume by 35%. The heart rate is also increased by about 15%, while the systemic vascular resistance will decrease by 25 to 30%. And as you know, this is due to vasodilatation, the effect of progesterone, the hormone of pregnancy, progesterone. This will affect the vessels by smooth muscle relaxation, and this will decrease systemic vascular resistance. This graph describes the main physiological changes that affect the plasma volume during pregnancy. As you see here in the graph, the dotted line here represents the plasma volume, and the interrupted line here is the plasma volume, and the dotted line here is the RBC mass. Both these will be affected by normal pregnancy. There is a gradual increment of both of them, but the rate of increment or the amount of increment of the plasma volume is much more than the RBC mass, that there will be a state of hemodilution in normal pregnancy. In the graph here below, there will be this shows the changes of mean arterial blood pressure that occurs in each gestational age. You see the nadir, we mean the minimum value of blood pressure at 20 to 24 weeks. You see that the mean arterial blood pressure returns to pre-pregnancy level at term, and then there is a further increment at labor by 20% and return to normal pre-pregnancy level at postpartum period. Clinically, the patient will have symptoms that simulate disease, like, for example, shortness of breath, edema of the extremities, especially the lower limbs, sinus tachycardia, and the patient will have palpitation, increment in the jugular venous pressure, clinical aspect of cardiovascular changes, breathlessness, edema, especially of the lower limbs, sinus tachycardia, the patient present with palpitation. There is fold and dynamically pulsating jugular veins due to hyperdynamic circulation, and forcibly beating cardiac apex. This will also affect the auscultation of the heart. There will be increased loudness of S1 and S2, exaggerated splitting of S2, loud S3 by 20 weeks. There will be systolic ejection murmur at the sternal edge in 96% of patients. There is transient diastolic murmur in 20% of patients, and sometimes there is continuous murmur due to increased mammary blood flow by in 10% of patients, increased blood flow to the breast. The ECG changes also in a pregnancy due to the effect of the diaphragm elevation on the axis of the heart. There will be left axis deviation. Regarding urinary systems, as you know, all the blood flow to all organs in the body will be affected, including the renal plasma flow, which increases. This will lead to increase in the glomerular filtration rate. There's also urinary stasis. This also due to progesterone effect that relaxes smooth muscle in the wall of the renal pelvis and ureters. This will lead to hydronephrosis, hydroureter, and this will increase the incidence of UTI and pyelonephritis in normal pregnancy. You see also the ultrasound of patients, especially in the third trimester. You will see the effect of progesterone and the effect of a gravid uterus pressing on the ureters. This will cause hydronephrosis, and this is one of the physiological changes of pregnancy. These changes also may be due to the effect of renin-angiotensin-aldosterone system, which with all of these hormones are increased in pregnancy. Prostacyclin increase, we know this is a local hormone which increases the blood flow to the renal arteries. The erythropoietin increases will increase the erythropoiesis. This is one of the hormones that are secreted by the kidneys. This table shows the rate of increment of renal plasma flow to be 60 to 80%. Glomerular filtration rate increases by 55%. Creatinine clearance also increases by 50%. Protein excretion increase, so there is up to 300 milligram of protein normally in 24-hour urine collection. If we collect the urine for 24 hours, we will see up to 300 milligram, which is regarded as normal. Urea in the blood will decrease. The blood urea, the amount of blood urea decreased by 50%. That's to say the normal value of blood urea in pregnancy is less than the non-pregnant level by 50%. If it is 45 in non-pregnant, it will be 25 in a pregnant lady. Uric acid also decreases by 33%, but rises with gestation. The bicarbonate also decreases. Plasma creatinine also decreases in normal pregnancy. Regarding the respiratory system, as you see here, there is elevation of the diaphragm here due to the effect of a gravid uterus, and you see this will affect the cardiovascular system, will affect the electrical axis of the heart, and this also affects the AP and transverse diameter of the thorax. These changes will increase the tidal volume, and also the O2 oxygen consumption increases by 20%. Alveolar ventilation rate increase. You know, alveolar ventilation means the depth of the breath. That's to say, there is increment in the depth of a breath. Deep breathing. While the respiratory rate is unchanged in a pregnancy. That's to say, there is 16 to 18 breaths per minute in a pregnancy and in a non-pregnant lady, while the depth of a breath is increased due to increment of the tidal volume. Here the graphs describe the main changes in the respiratory system in the pulmonary function test. You see here that the vital capacity and the inspiratory reserve volume will be unchanged, while the tidal volume and the inspiratory capacity will be increased, and all other values including expiratory reserve volume, functional residual capacity, residual volume, all of these decreases in normal pregnancy. As we said before, there's a state of physiological hyperventilation during normal pregnancy, and this will be caused by progesterone. Why this happened? This happened due to the need to secrete the extra CO2 produced by the fetus. This state of hyperventilation will lead to respiratory alkalosis, and should be buffered. All the enzymes and all the chemical reactions in the body requires normal pH. So when there is respiratory alkalosis, this should be compensated for by metabolic changes, including increased carbonic anhydrase. This enzyme will be increased in RBCs, and also the kidneys will excrete bicarbonate, more bicarbonate excreted. So this will compensate for the state of respiratory alkalosis. In this graph here, we see the oxygen hemoglobin dissociation curve in a pregnancy. You see that there is shifting to the right in the mother and shifting to the left in the fetus of this curve. That's to say, when there is shifting to the right, this will facilitate a release of oxygen from RBC to the tissues, so increase the bioavailability of oxygen. That's to say, decrease affinity of hemoglobin to oxygen. So the oxygen is readily released to the fetal tissue. While in the fetus, the fetal hemoglobin is has more affinity to oxygen. Okay, so there is shifting to the left in the fetus. Why this occur in the mother, in the pregnant lady? There's shifting to the right. This occurs due to increase in the product of glycolysis in RBC, which is 2,3-diphosphoglycerol. This will compensate for oxygen at hemoglobin binding. The rate of increment of oxygen is about 20%. Resting minute ventilation increases by 15%. Tidal volume, we said that is increased, but the respiratory rate is unchanged. Functional residual capacity will decrease. So the oxygen pressure increases and the CO2 pressure decrease. Vital capacity and forced expiratory volume in the first second is unchanged. So these two factors may be used to monitor respiratory disease like asthma during pregnancy. Regarding metabolism and nutrition in a pregnancy, the energy cost estimates at 2,000 calories per day in late pregnancy, which is fairly met and not require much major adjustment to calorie intake. The calorie intake may be increased by 250 calories only. 250 calories only. What we need to supplement pregnancy? We need to supplement pregnancy by folic acid to decrease neural tube defect, by calcium and iron. The total weight gain in pregnancy ranges from 7 to 17 kg with average of 12.5, and it is about 0.5 kg per week for the last 20 weeks. This increment in weight will be distributed as follows. The fetus and placenta accounts for 5 kg. The increased body fat about 3 to 4 kg. Uterus and breast about 1.5 kg. Blood accounts for 1 kg and extracellular fluid by 1 kg. The effect of pregnancy on basal metabolic rate, you know that there will be increment in basal metabolic rate by about 15 to 20%. Regarding carbohydrate metabolism, glucose and amino acids metabolism are altered in pregnancy. Why this happened is to supply the fetus with its nutritional needs. So, the fat that is laid in the first half of pregnancy will help the mother meet the demands of the fetus in the later half of pregnancy, where the demands of the fetus is more. Progesterone will have a stimulatory effect on appetite in the first half of pregnancy. There will be diversion of glucose and fat to be more excreted in the blood, so there will be more available glucose and free fatty acids in the blood to the fetus. The hormonal changes that occur in pregnancy, including estrogen increase, which also increases the prolactin, and the human placental lactogen, these will be secreted from the placenta, and this will generate a maternal resistance to insulin. These are the main hormones that antagonize the action of insulin. So, maternal glucose use declines, in gluconeogenesis increases, so the glucose will be more available in the maternal blood to be shifted to the fetal circulation. In the later pregnancy, the mother energy are met by metabolizing peripheral fatty acid. The glucose will be transferred to the fetus by the placenta by facilitated diffusion. So, glucose will cross the placenta while insulin will not. Insulin will not cross the placenta. The hormones that are increased in the later half of pregnancy, which are the human placental lactogen, which is the main cause of increased insulin resistance in later half of pregnancy. These hormones will antagonize insulin and is responsible for the appearance of gestational diabetes in some pregnant lady. The most important change in normal pregnancy will affect the postprandial, that's to say, after meal blood glucose, while the fasting blood glucose will decrease. That's to say, when we need to measure blood glucose during pregnancy, we will use the postprandial blood glucose because this will be affected by the antagonistic hormones, the hormones that antagonize the action of insulin, while the fasting blood glucose will be lower in normal pregnancy due to fetal consumption of glucose. These changes will affect both basal and stimulated insulin secretion in a pregnancy. The ability of pancreas to meet the increased demand of insulin secretion is achieved by two ways: by cell hyperplasia and hypertrophy of the pancreas, pancreatic cell hyperplasia and hypertrophy, as well as increased rate of insulin synthesis. In most women, the pancreas will compensate for these needs, but in some of these women, the endocrine pancreas is unable to respond to these metabolic demands of pregnancy, and the pancreas fails to release the increased amount of insulin required. As a consequence, there will be a state of glucose intolerance, that's to say, loss of control of metabolism of blood glucose, and this will result in gestational diabetes. So gestational diabetes appears after 20 weeks of pregnancy at the gestational age of 20 weeks. As a consequence, there is a loss of control of metabolism of blood glucose, and there will be gestational diabetes after 20 weeks of pregnancy. After birth, when the increased metabolic demands of pregnancy are removed, when the placenta is delivered and the effect of the hormones will be lost, so the metabolic changes will return to non-pregnant level. So the diabetes will disappear. Regarding lipid metabolism, there will be increment in lipolysis from the second trimester, so that the concentration of free fatty acids in the fasting level will be increased, and this will provide substrate for the maternal metabolism, leaving the glucose for the fetus. This will increase the risk of ketoacidosis. Regarding thyroid hormones, as you know, thyroid-binding globulin production is increased due to increased estrogen. Estrogen will increase thyroid-binding globulin, so that total T3 and T4 will be increased, while free T4 will be in the normal range. Why T3 and T4 production is increased, especially in the first trimester, due to direct effect of the SCG, which is secreted in early pregnancy by syncytial trophoblast. This hormone will have a stimulatory effect on the thyroid gland due to the common alpha subunit of HCG and TSH. When T3 and T4 production is increased, there will be decrement in the TSH in early normal pregnancy as a result of negative feedback. Regarding gastrointestinal system, the anatomical changes, that's to say the pressure from a gravid uterus, alteration in the position of viscera. For example, appendix will move from the right lower quadrant to the left upper quadrant as the uterus enlarges. So sometimes this will cause difficulty in diagnosing appendicitis, but because of the change of the position of the appendix. Sometimes the pregnant lady will have loin pain, and this will be diagnosed as appendicitis. The GIT also will be affected by the progesterone effect on smooth muscle relaxation, so there will be delayed gastric emptying, constipation, biliary stasis, increased risk of pancreatitis. Regarding hematological changes, pregnancy is a hypercoagulable state due to increased fibrinogen and clotting factors and reduced anticoagulant system and fibrinolysis. There will be also a stasis of the blood vessel due to the effect of a gravid uterus, pressure by gravid uterus, and also there is vasodilatation, so there will be stasis of a blood. Both these, increment in clotting factor, especially fibrinogen, and stasis, will increase the incidence of thromboembolism in a pregnancy, increase the risk of thromboembolism in a pregnancy. You know that we can give anticoagulants in a pregnancy, but warfarin cannot be given in the first trimester because it crosses the placenta and it is teratogenic, and it also cannot be given in the third trimester because it will cause intraventricular hemorrhage in the fetus. The changes in the hematological system also will affect the white blood cell count, which increase in a pregnancy due to increment in polymorphonuclear leukocytes. The ESR will also be increased due to increase of fibrinogen. Platelet will not be affected. As we said before, plasma volume increases, RBC mass also increases, but not to the same degree. So there will be a state of hemodilution. Previously, this was erroneously called physiological anemia of pregnancy. No longer we use this term. We call this as this state hemodilution, because this is not a true anemia. This is due to mismatch between volume, plasma volume, and RBC mass increment. Due to this hemodilution, the hemoglobin will be decreased in a pregnancy, so that the pregnant level will be 10.5 to 11, while in non-pregnancy it is a 12 gram per deciliter. Other hematological indices, namely hematocrit, RBC counts will be decreased, MCV will be increased, mean corpuscular volume will be increased. Why? This is because new RBC are larger. Main other indices will be decreased due to state of hemodilution. The least affected value is ferritin, which is the storage of iron. So we can use it to diagnose iron deficiency anemia in a pregnancy. Most likely used is serum ferritin because it's least affected investigation in iron deficiency anemia in normal pregnancy. Regarding immune system, there will be change in the immunological system in the body. You know, the fetus is an allograft. That's to say, it is genetically different to the mother. So this will require to change the immunity especially there will be non-specific suppression of the local immune response at the maternal-fetal interface. This will cause maintenance of pregnancy. If this change of immunity is not happened, there will be miscarriage, abortion. Antibodies are transferred by the placenta if they have low molecular volume. So IgG crosses the placenta, while IgM will not cross the placenta due to its large molecular volume. There are immunological diseases that affect the fetus during pregnancy due to ABO or Rh incompatibility causing hemolytic disease. There are also immunological diseases that affect the pregnancy due to ABO incompatibility or Rh incompatibility between the mother and the fetus, and this will cause hemolytic disease of the newborn. And also there is a hemolytic disease that affects the fetus and the newborn due to ABO and RH incompatibility between the mother and the fetus. Antibodies that can cross the placenta, which are either due to Graves' disease, which stimulate TSH receptors, or in patients with Hashimoto's thyroiditis that destroy developing fetal thyroid. These problems occur or affect the fetus due to crossing antibodies that cross the placenta. There are other physiological changes that affect the reproductive organs. There will be increment in the size and the weight of the uterus to reach 1000 grams at term. There will be changes in affecting the cervix and the vagina during normal pregnancy, and also changes that affect the breast, which prepare the breast for lactation after birth. This will include changes in the nipple, changes in the size of the areola, venodilatation, increase in the fat, and the glandular enlargement of the breast. There are also dermatological changes that may occur during normal pregnancy. These include increased pigmentation in a pregnancy, the appearance of linea nigra between the umbilicus and the symphysis pubis, which is a dark line between the umbilicus and symphysis pubis. Also the striae of pregnancy due to increment in the diameter of the abdomen. Also, the face might be affected by increased pigmentation. This is called chloasma. There might be spider nevi in normal pregnancy. There is a state of palmar erythema. These two effects are due to estrogen hormone, which is increased during pregnancy. So you see that there are many physiological changes that affect all the organs and systems in the body during normal pregnancy. And this will prepare the mother and fetus for this journey during pregnancy and labor. Thank you very much.